Hi, Lauren. Hi, good morning.
Good morning.
How are you?
I'm well. How about yourself?
I'm good. I'm good. So you're Lauren. Nice to meet you.
Same to you.
Wendy's here too. Let's get her in. I'm Kim, by the way. I work with the,
Nice to
yeah,
meet
nice to
you.
meet. Exactly. Hang on here. Hi.
Morning.
Morning,
How are
Wendy.
you? All right, Wendy. I'm just texting people. How are you? I'm Kim Branch. Nice to meet you both. I actually work with the association more on what you would like call an association manager side, executive director type role. So the company I work for is actually Chicago Association Management. So CAC is one of my clients. I've got sorry, a couple other people should be joining us shortly. One is Sharmalee. You guys know Sharmalee, right? Or do you call her Dr. Ninehouse? I don't know what you refer to her as. She should be on any minute. She is going to actually not only present, but she's going to moderate today. So she'll be on the whole time. And then in the beginning, she'll have a few slides to go through that are for our organization. And then from there, she will go into her presentation. And then I can't remember, Wendy or Lauren, are either of you going to be presenting the slides for the research project?
I think we'll do it together. And it looked like Charmelia included the slides, or the few slides that we had at the end of her deck, so we shouldn't need this
Yeah.
much sharing.
So do you want to do that from your own computer? Is that easier to share your own screen?
I think Charmelia will share because our slides are at the end of her deck, so
Okay.
whatever she prefers.
Okay. Cool. Gotcha. Okay. So
Or I guess one of us could share if
yeah,
Charmelia
I
prefers
can't.
to.
I think it's fine. Hold on a minute.
Charmelia's pretty tech savvy, so I'm sure she'll be fine to share.
Okay, somebody else is coming in. Here we go. Asher. Okay, Asher's with our organization. They'll help run this event today. I actually will be hopping off from 9 to 10 for another call. Asher will be on, and so will Shelby, who is one of our tech people. That way, if something goes wrong, they'll be here. And they also have backups of the hi, Asher, good morning. They also have backups of the presentation on their desktops. So, we're covered if somebody ends up getting dropped from the conversation here. And then Shelby's probably on. Shelby, are you on? I have a feeling.
I'm here.
Okay. So, uh, Sharmalee, that was not you who texted me, was it?
Yeah, it was.
Oh, it was. Okay, good. So you got it then. Okay.
Yeah,
I
I figured it
just
out.
responded saying, I'll send it to you, but I don't know who this is because I
Yeah,
didn't write
I know.
anyone's
That's why I
name.
was like, Kim, please send it to me, but I guess I should have said
Okay,
I'm
gotcha. Perfect. Okay, so there's going to be people joining now, Shelby, that I can tell are not, they're just
Oh yeah, I'm not
obviously
letting anyone in.
registering. Yeah,
Yeah,
I
I'm
don't
not
think
letting
anybody
anyone in.
else, not for right now. I think Dr. Kumar will come on at closer to like 9, I think.
Okay.
So something like that. So, Sharmalee, now that you're moderating, do you want us to send you the deck for Chicago Association Management, or do you just want us to run it from our desktop and then we'll just say next or whatever, or we can just forward the slides for you? It's just a short, introducing CAC, talking a little bit about the day and, what the agenda is going to look like, if you have technical difficulties, that sort of thing.
Yeah,
I'll
that's
show it
fine.
right here.
You have the deck, then you can just run through it. That's fine.
Okay. So let's run through it real quick for you, just
Yep.
because I know you haven't seen it yet. So this
Haven't-
is the first slide,
Mhm.
and this is what will be on when everybody starts joining. And then what's the next one? I don't know, Shelby, are you running it or?
Yeah, I'm running it.
And then you can keep going. So this is the housekeeping slide, Sharmali, that you'll want to talk about. This is not a webinar, so everybody we are asking that they keep their video and audio off during the webinar. It says during the first half of the webinar and the closing of the webinar. I think we just need to keep it off the whole time. I don't know if we can change that real quick.
Yep.
Just say during the webinar.
Okay, so during the webinar.
Yeah, during the webinar. And if for some reason, Sharmali, you decide at the end you want everybody to be able to be seen and heard, that's fine. You can just tell them that. But most people don't expect to be. So not everybody's really video ready all the time when we're running these things.
Yeah.
Okay. And then we use the chat for questions, but we also want to give them the opportunity if they want to network and say hello and just kind of introduce themselves. We usually say that. And then webinar evaluation, we will actually be sending one out and we'll post it into the chat box at the end, but we'll send it out to all attendees so they don't really need to worry about it. You know what I mean? If they don't, they don't have to worry about pulling it from the chat if they don't want to. In fact, we could probably even erase that too, Shelby, just because, you know what I mean? People are
Do you just want me to take out this whole sentence? Please copy
yeah,
and
just
paste.
say we will send it to all attendees.
Okay.
Or email it or whatever. Okay, and then the next one. Yeah, so if there's issues, or Shelby, you can also change this to you. It doesn't matter.
Okay.
And I'll just make sure I'm monitoring my email in case, you know, people are struggling or can't get in or need a link or what have you. And then the next one, okay, we got to change exhale.
Okay.
840, sorry. Just put presentation is fine.
Okay.
And then 9:15, not a panel, it's just a Q&A, right, Sharmali? Q&A at 9:15, or do you want it at 9?
I think it will probably be closer to like 9:10 or something like that.
Perfect.
And it should just say Q&A.
I would say Q&A.
Okay.
And then 9, I don't know.
15. Yeah.
Okay. To put presentation. And you can put,
Well, I think we were going to do kind of like a quick break because.
oh yeah, we want to
Yeah.
take a break.
Yeah.
We don't have as many, no break, sorry, put a break there.
No
if you
break
can.
here, okay.
Sorry.
And then 9:20 can be the presentation.
Yeah.
Okay.
And then
And then I think he said he'll be done at like 10. So yeah,
10.
maybe questions at 10.
Yeah.
And then
Okay.
10:15 closing remarks or something like that.
Yeah, something like that.
And that's another Q&A, is that right?
Yes.
Mhm.
Okay.
And then 10:15, I would change the closing remarks to, yeah.
Okay.
So we'll be down a little earlier than we thought. You could change the spacing on this if you want, Shelby.
I will. Yep.
Weird. And then the one important thing, and I know we only have a few more minutes here, Sharmali, so AstraZeneca, as you know, has helped us with this as a sponsor. So all we need to do is just make mention, and there's a thank you slide next. I'll show it to you.
Okay.
And if you could let them know that Kara Levin will be available via chat if anyone has questions for her. So she's on, but she's not going to come on and say anything.
Okay, so thank you slide for.
Is there not one for?
No.
Yes.
This might not be the right one. I feel like we're working off the wrong.
I pulled this from the T drive.
Oh,
Is that not correct?
hold on.
Yeah, because where are our pictures? Because that's one,
Yeah,
but
this isn't the right one.
the one that you sent me though, still doesn't have
Where
anything
did you
about
find this? Where's this one?
AstraZeneca.
This
Where's
one I
this?
pulled from the T drive, from the program folder.
Can you go down one? Or up one, I mean? I'm sorry, up. Up again. Where is the up one more time? It was in there. I don't know where it went. Hold on.
Yeah, I think our pictures were after, like right before the questions, and then I had thank you for attending today, but then it didn't, I don't have an AstraZeneca slide, so.
Let me see the one that was sent to you. There might be two, sometimes, you know, the versions, because we all work from the same T drive, we have to save them as different versions, which can be a, you know, kind of a bummer. Here we go. Hang on a minute. No, that's Kamara's presentation. All right, hang on a second. Okay. Okay, I think I have the right one.
You want to just email it to me and then I'll pop in the Astra?
Yeah, I'm just gonna
AstraZeneca
double
slide?
check to make sure that I do though. No, why? Where did the thank you slide go? That's so weird, you guys. Hold on. I
Did you
feel
create it in
terrible.
Canva, Kim? Would it be in the original Canva?
Yeah, but
file?
it's in a, I got it here. I don't know why it's not in that one. I must have had two different versions, you know. If you want, we can just,
If you can just send me the one that has the slide, I'll just
yeah,
pop
I'm
it
trying
in.
to get that for you. Yeah, I'm gonna do that right now. And then you can just pull that out. Is that what you're saying? Pull
Yeah,
that
yep.
slide out
Mhm.
and put it in.
And should it go, would it go then before the presenter slide?
Yeah, so you're gonna talk about CAC, and then right before we present, we want to thank,
Okay,
yeah,
so I'd actually want to
AstraZeneca.
put it probably before this one, between this one and this one.
Yeah, and then
Yeah.
do you have the presenter slide? Because.
Yep. Is
Okay,
that,
that's it, yeah. Mhm,
yep,
mhm. Okay, yeah, so as long as we get that.
right. So
then
that'll be
that-
the last one, Sharmalee, that I'll show before we actually start the presentation. And then when we're at the point where we're going to do Q&A, then I'll just pull up these slides for both the Q&A sessions. And
Okay.
then at the end, we just have this last slide.
Mhm.
Okay, I think I've got the right one here for you.
Okay.
I just want to make sure I'm sending it to you. So this will have the thank you slide in here. Let me just double check because I'm a little concerned. I don't know why it's not in that one. Okay, here. All right, I'm sending it to you right now.
Okay.
And just use the, there's a thank you, it says thank you to corporate sponsor AstraZeneca.
Okay.
Okay.
I'll let you know as soon as I get it.
All right, it's slide number 3. So do you want to mention like when Shelby says we're going to start, she will have us like be quiet for at least what, like a minute, Shelby, while how long do you want everyone to sort of?
Yeah, I say be quiet for a minute because it'll take a while for the people to pop in from the waiting room. So just, do a short minute pause.
Okay.
I don't have that yet, Kim. Keep
I know
checking.
it's, of course, my,
Just to clarify, should we turn off our videos as well once we start?
Yeah,
Yeah,
I would say yes, and then I'll introduce you and then you can pop in.
Sounds good.
Shelby, of course, my email is giving me problems right now.
Okay.
So go into here, I'll just chat it to you so you know where to go. It'll probably be better. Here, hang on. I can't believe my email is doing that. This is always, this is what happens.
Is it just saved on your T drive, Kim, or would it be in Canva?
Yeah, it's in the T drive, but are you under association manager or yes, right? Co-host?
Yeah, I just renamed myself.
So I'm going to put it in here. Okay, sorry. There you go. See if that works. Now, why is my email not working?
Okay, let me see if I can find this.
You guys hearing my beeps telling me I'm not working? I can't do anything. It's like frozen. My whole email's frozen. When it rains, it pours.
Yeah.
Right? I'm going to try to close everything out. I might have to dial back in, but Shelby, I'm going to hand over everything to you anyway, as far as host is
Let's just make
concerned.
sure that I'm host before
Okay, that's what I mean. I don't want to.
Yeah.
Don't want to worry about that.
CAC programming.
Okay, just made you host. Asher, this is a great one for you to be on. Since we're having all these issues in the
Shelby,
beginning.
I just added the AstraZeneca slide to the version in T drive of this presentation.
Okay.
So if you pull that one up, it'll be in
All
there.
right.
You might need to shuffle it a slide up.
Yeah,
or
I'll just
down. I
pull
didn't
that
know exactly where you want
slide.
it, but
Yep, since we did make some changes, but I'll pull up this one again.
I don't see anybody in the waiting room. Do you?
Yeah, there's 17.
Okay.
Kim, are you co-host? Can you make Asher, Sharmali, and
You're host now. You should be host.
okay. I was just gonna say make them co-host while I'm trying to pull this up. Just so if someone could go in and maybe chat.
Can you make me host again then? Because I made you host.
Okay. All right, so I made you a co-host. You can make everyone else a co-host.
Okay. And then you just want to keep an eye out for Dr. I have to hop off. Remember, I have another thing to run. So at a little before 9.
All right, I'm pulling up the presentation.
How come I can't make Sharmali? Sharmali, are you already co-host?
No.
I can't make her co-host. Why can't I make you co-host? Do I have to be host to make her co-host?
I don't think so, but let me just pull this over.
I'm struggling today. I'm so
All
sorry.
right. Thanks, Asher. I'm going to pull this over. Okay, so right
Is
now,
Sharmali, is Sharmali co-host? I honestly, it's not letting me do it.
okay, hold on just a minute.
I'm sorry. I don't know what's going on today.
I'm just getting the slide deck ready.
Let me try it again. I can't. I don't know if it's because I'm co-host. I can't make her
Okay.
co-host. I'll send a little message to everybody that we're Gonna start soon.
All right, so Sharmalee and Asher, you should now be co-host. And then let me just get my screen share set up.
And I'm gonna close myself out. Find my video.
All right, now let's make sure we have this in the right spot. I have our About CAC slide. And then I have the thank you to the sponsor. And then we have the slide to start the presentation, followed by the speakers. Does that look good?
Yeah.
Okay. Let me save it and then I'll open the,
Do you want Lauren and Wendy and Asher all to be off video right now, right?
Yeah, they are.
So, what? Oh, you don't. All right, I'm gonna hide their view. I see them on my view then.
yeah, you can hide.
It's okay. I hit them.
Okay,
Just
let me
hiding
stop
on
my
video
video.
participants.
I'm gonna mute my audio, but I will be here. All right, I'm gonna let everyone into the waiting room.
Can we put it on the first slide?
Oh, yep.
Thank you. Okay, great. Well, welcome to everybody to our webinar today. And we apologize for the slight delay. We were just having a few technical difficulties on our side, so we appreciate your patience with everything. So again, I'd just like to welcome everyone, both CAC members as well as guests, to our CIC Asthma Practice Management Forum. We have an exciting set of presentations today. Next slide. So just a few housekeeping issues before we get into further introductions. So if you could please, all attendees have your video and audio off during the webinar. We will be using the chat feature you can either introduce yourself, say hello to other attendees that are here today. And we will have some time for question and answers for the presenters. And you can go ahead and type your questions in the chat and we will be answering them during the Q&A portion of the presentation. And then we would definitely love to hear your feedback about these presentations. So we will be sending a webinar evaluation to your email after the today's talks. Next slide. So if you are having any technical difficulty, please feel free to contact Shelby Hoffman or Asher Robeson, and you can do this via the chat feature, or you may want to write down this phone number right now. So in case for some reason you're unable to get back into Zoom for any reason, you can call this phone number, or you can also email kbranch@chicagoasthma.org. Next slide. So just a brief overview of today's schedule. So again, we are going to be talking, our overall theme is the research across the spectrum of asthma. And we will have a presentation on severe asthma, updates there, and then we'll have a Q&A, and then we'll have another presentation and then closing remarks. Next slide. So a little bit about the Chicago Asthma Consortium. The mission of the Chicago Asthma Consortium is to improve quality of life for those living with asthma through advocacy, education, and collaboration. We are a convener of medical and public health professionals, business leaders, government agencies, community-based organizations, and other individuals that are dedicated to raising the awareness of asthma and improving the quality of life for those living with asthma. So if you're interested in learning more about the CAC, if you're not a member, you can go to the CAC website to become a member, consider joining a committee, even consider joining our board of directors. And there's other ways to become involved by just following us on Twitter as well, and social media. Next slide. Today, we'd like to thank our corporate sponsor, AstraZeneca, who is helping put today's program on. Kara Levin from AstraZeneca will be available via the chat feature during the presentation as a resource if you have any questions or if there's any information that you need. And again, the CAC definitely appreciates AstraZeneca's partnership and support in this programming and other efforts. So again, thank you for our community partners to also help make these events happen. And I think we'll start with introducing the speakers for today. So I apologize, I didn't mention my name earlier. My name's Charmelia Nienhuis. I'm an associate professor of medicine at the University of Illinois, and I'm moderating this meeting, but I will be also giving the first presentation. The next presenter is Dr. Rajesh Kumar, and he is a professor of pediatrics at Northwestern University Feinberg School of Medicine. Next slide.
That is it. We're going to go ahead
Okay.
and start with the presentation.
Okay. Just give me a moment to get set up. Okay. Shelby, can you see my screen okay? I
Yes,
just wanted
yep,
to make
looks
sure.
good.
Okay, great. I just wanted to make sure. Okay, so as I said earlier, I'm going to be talking about some new approaches to managing severe asthma. So difficult to treat in severe asthma. Today I'm going to be talking about some of the new GINA guidelines for treating difficult to treat in severe asthma. This is really a practical guide for both primary care and specialists, and it does include information on a decision tree on really how to approach people with uncontrolled asthma, as well as that have recurrent exacerbations despite therapies, high dose therapies. This also, what's nice about the Global Initiative for Asthma, or GINA, is that it also includes strategies for various clinical settings. So because it is global, they do look at considering low resource settings where maybe not everyone has all the resources that are maybe found in a tertiary medical center. So a little bit about the GINA strategy. Again, actually, it's the GINA report, and it's really not a guideline, but it's an evidence-based strategy to look at how to translate the evidence from clinical trials into clinical practice. And these recommendations are framed and not really answers to specific questions. So the recent update of the NAEPP guidelines or the US national guidelines, those really focused on isolated questions to the approach of asthma, and so that's why it wasn't a full update. But overall, the GINA goals of one of the main goals is to prevent asthma deaths and exacerbations and also improve symptom control. There's also a better understanding of the underlying disease processes, also looking at the behavior of health professionals and patients and caregivers. And then again, as I mentioned, really the implementation into clinical practice, and then looking at some of the global variation in populations, medication access, and health systems itself. So as I said, for the GINA approach, or strategy focuses on the main goals of asthma treatment, which are overall symptom control and risk reduction. So symptom control being fewer asthma symptoms, no sleep disturbance, no exercise limitation. And then as far as risk reduction, really maintaining normal lung function, preventing exacerbations, asthma deaths, and avoiding medication side effects. The one important thing to think about is that even though these are our goals of treatment, that the patient's or caregivers' goals may be very different from this. So that's just always something to consider, that, well, again, these are overall typically the goals of asthma treatment. It's definitely very important to assess what the patient's goals are as well, and see how they might align with these, or how to assess these and have some concordance with that. Also, it's important to assess both the symptom control and the risk reduction, because sometimes symptom control may be okay, but risk reduction is not. So that's something to evaluate and make sure that you're assessing both. Often we'll assess symptom control by using tools such as like an asthma control test or asthma control questionnaire, but the risk reduction does not typically address those. So those are some additional questions that providers would need to address. So one of the things that I think, even as a healthcare provider, it's something that we often use these terms interchangeably, but they really aren't, are these terms of uncontrolled, difficult to treat, and severe asthma. So one thing that the GINA does do well is to try to differentiate this. So uncontrolled asthma, this is somebody that often has frequent symptoms or flare-ups or exacerbations. And this can include people that have severe asthma, but may also be many patients that have untreated mild asthma. So if they were able to take medications on a regular basis, then they may not actually have uncontrolled asthma. And many of you probably know the statistic that there's quite a few people that have uncontrolled asthma in the US, on the upwards of 40 to 50% of adults with asthma. Now, difficult to treat asthma is asthma that's uncontrolled despite being on appropriate therapy, such as medium or high dose daily therapy. And they may have contributory factors that lead to difficult to treat asthma. And this can include an incorrect diagnosis, incorrect inhaler technique, poor adherence, and also comorbid conditions. And then severe asthma itself is a very much smaller proportion of patients that actually they have uncontrolled asthma despite maximal optimized therapy and treatment, and even if those contributory factors are treated. And the symptoms typically worsen when high dose treatment is decreased. So again, these patients are what we would say relatively refractory to corticosteroids, but not really completely. And So those are some of the different terminology for these. So as I mentioned, how common is severe asthma? So this is based on data from a Dutch population of adults with asthma. So this is looking at, there's of patients with asthma, about 24% were on high intensity treatment. So that means like a high dose of an inhaled steroid plus a long acting beta agonist, or a medium dose of an inhaled steroid, long acting beta agonist plus an oral steroid. And so out of those, about 17, or out of the whole population, about 17% actually had this difficult to treat asthma. And from there, then only about 3.7 had this really severe asthma, meaning that all their contributory factors were treated. And despite this, they still had required high intensity treatment, and they still had poor symptoms and such. So overall, severe asthma is not as common as we think. Uncontrolled asthma, as I said earlier, is much more common than severe asthma itself. So as I mentioned earlier with the GINA strategy, this is they have these tools to really help providers implement the management and treatment, as well as the diagnosis of severe asthma. So they have these decision trees. So this is something that's quite new. In 2019 is the first time they began having these. And this was really helpful than more than just, paragraphs of information of, okay, address this, or, look at this. So this is kind of a new way to help, again, implement the severe the diagnosis and management of severe asthma. So of course, if you have somebody that has this difficult to treat, okay, so not necessarily severe asthma yet, but if they have difficult to treat asthma, some of the first things that you're going to want to do is confirm the diagnosis. And as I mentioned earlier, look for factors that are contributing to symptoms, exacerbations, and poor quality of life. So as I mentioned, when we investigate some of these factors, we're looking at comorbid conditions. And I briefly mentioned this, but some of the comorbid conditions could be chronic sinusitis, obesity, acid reflux, sleep apnea, and other psychological or psychiatric disorders. Also assessing inhaler technique and medication adherence. Also investigating for persistent environmental exposures, so allergens or toxic substances that could either be in the home or in the workplace. Also, you would want to assess if they're overusing albuterol or other short-acting beta agonists or short-acting medication. And then, as I mentioned earlier, also assessing for medication side effects. So also, when you're confirming the diagnosis, you definitely want to think about these alternative diagnoses like COPD, or somebody that may have recurrent respiratory infections, because that could be a mimicker of asthma as well. So after you confirm the diagnosis and looking for some of the factors, the next thing would be really optimizing the management. And this includes doing asthma education, also optimizing the treatment. So again, if you do find that there are improvements that could be made in inhaler technique and adherence, helping patients or caregivers with that. Also treating the comorbidities that may have been found in the previous step. And also at this point, considering really non-pharmacologic therapies in addition. So if they are smoking, considering smoking cessation, consider weight loss if somebody's obese, increasing physical activity, considering breathing exercises, and other things like mucus clearance. So clearing, doing procedures and that the patient can do at home to help clear mucus if they are mucus overproducers. And then at this point, you could also consider adding a non-biologic medication, like a long-acting beta agonist, if they're not on that, a leukotriene modifying agent, or a long-acting muscarinic antagonist as well. So once you begin that management, again, this is a difficult to treat asthma, so we're not to severe asthma yet. You want to review the response after 3 to 6 months. And at that point, then you may want to consider, is the asthma controlled, yes or no? And if no, then you could consider stepping down some of the treatment or continuing optimizing the treatment. Now, if yes, at this point, then you may have a diagnosis of severe asthma. Once you, and typically at this point, then you refer to a severe asthma specialist. So that could be a pulmonologist or an asthma or allergist immunologist. And here often there is when we begin to assess this severe asthma phenotype. And I'll talk a little bit about what that means and really look at some of the factors that may be contributing to the symptoms and exacerbations again. So what is a phenotype? So a phenotype is an observable characteristic of a disease. So allergic asthma is a phenotype of asthma, or another one would be eosinophilic asthma. So if somebody has allergies that kind of drive their asthma, then again, we would consider that they have an allergic phenotype of their asthma. So some of the ways that I phenotype my patients are by obtaining a CBC with differential, and also obtaining an exhaled nitric oxide test, which is a point of care test that can be done typically in a specialist clinic, or I have been seeing that some pulmonary function labs are performing this test as well. Also getting a total IgE, which helps in determining if they have allergic asthma, but then also doing allergy testing, whether it be an immunocap blood test, which both primary care and specialty providers can obtain, or doing skin testing in the clinical setting. Of course, also getting spirometry or full lung function tests, and then also considering getting some imaging, and in some cases, looking at aspergillus precipitans, which would look at a specific endotype of asthma. Other important characteristics that I do to phenotype is looking at exacerbations, airway reactivity, and then to see if they also have a history of nasal polyps or aspirin sensitivity or sensitivity to NSAIDs themselves. So in the GINA strategy, the next, when you, after you phenotype your patient, you want to ask, does this patient have a type 2 airway inflammation? And this is typically an eosinophilic or allergic type of inflammation. So typically people will, if you have type 2 airway inflammation, again, if you have blood eosinophils, which is a type of white blood cell, if it's elevated to greater than 150, if you have a exhaled nitric oxide, which is a marker of eosinophilic airway inflammation, greater than 20, sputum eosinophils is here too. This is rarely done in clinical practice here in the United States, but has been often done in the research setting. And then again, if the asthma is allergy driven, or if you need maintenance oral corticosteroids, then this may mean that your patient has type 2 inflammation. Typically, somebody would, you would want to repeat the blood eosinophils and nitric oxide up to 3 times on their lowest corticosteroid dose, if possible, so you can assess to see if they have this type 2 inflammation. Now, if so here, once you decide this, then again, you may want, if somebody does have type 2 inflammation, then you may want to consider, again, some non-biologic treatments, looking at adherence tests and making sure that they're taking their, either have access to the medication or taking it properly, and are taking it properly. And you could even consider increasing the inhaled corticosteroid dose after that. But if there is no evidence of this type 2 inflammation, then we do focus on talking about avoiding exposures, tobacco smoke, allergens, irritants, thinking about getting, if you haven't already, getting a CT of the chest, maybe even referring for a bronchoscopy, and then considering some add-on therapies, which are such as tiotropium, which is a long-acting muscarinic antagonist, or a macrolide, which is an antibiotic, and also considering adding on a low dose of an oral steroid. Also, at this point, we are thinking that to really look at what therapies they're on, and if you've added a leukotriene modifying agent and that has not been effective for the patient at all, then actually stopping those, because patients may not need that. And then also considering bronchial thermoplasty, which is a procedure that pulmonologists can do, that could potentially help improve some asthma and reduce asthma exacerbations. So I wanted to talk a bit more about considering adding a long-acting muscarinic antagonist like tiotropium or azithro to patients that do not have type 2 inflammation. So this is approved for patients that are 18 years or older. And you would add that to somebody that's already taking a medium or high dose inhaled corticosteroid with a long-acting beta agonist. And it has been shown to have a modest improvement in lung function, as well as reduce asthma exacerbations. But really, they haven't seen large improvements in asthma symptoms. So it may reduce exacerbations and lung function, but it may not improve symptom control, which, as I said in one of my first slides, is that again, assessing what the patient wants and what the provider, that's sometimes where there's some discordance. Also, adding on a macrolide such as azithromycin. So there's some new evidence showing that, adding this on in patients that have adults that have severe asthma, that this could improve asthma symptoms as well as exacerbations. So again, right now, specifically, the recommendations are to consider adding on specifically azithromycin and not just macrolides, because azithromycin is the only one that has been where there's the most evidence for. So that's something kind of new and something to be considered. So again, if somebody does have that type 2 inflammation, we would consider, again, doing those adherence tests and maybe increasing medication. Now, after you do assess, do some of these modifications in management and assess after 3 to 6 months, and patients are still having exacerbations more than 2 times per year, or has poor symptom control despite all of these treatments, and still have these eosinophil and allergic biomarkers, or are requiring oral corticosteroids, then at this point, you may want to consider adding on a biologic that targets this type 2 inflammation. And some of the things to really consider prior to starting a biologic are, first of all, what predictors are you going to use to assess the response? So are you looking at exacerbations? Are you looking at symptoms? Also looking at local payer eligibility criteria. So each payer in, that this is something we struggle with. Each payer has different eligibility criteria for starting a biologic. So that's something to definitely consider. Also, the cost for the patient, how frequent the medication needs to be administered, the route of administration. So many of the current biologics are given subcutaneously, so right under the skin as an injection, but there is one that is given as an IV infusion. And then also with the patient preferences. So I get this question a lot from people as, oh, which biologic to start? And I really follow all of these things prior to considering starting a biologic. So I can't necessarily just say, oh, I would do this one or this one. It depends on all of these factors. So if for some reason you're unable to start a biologic, maybe due to, again, local payer eligibility or patient preference, then you may want to consider a higher dose inhaled steroid if they're not on it. Again, going back to some of that non-pharmacologic and non-biologic add-on therapy. So if they have type 2 inflammation and you're unable to start a biologic, then maybe considering the tiotropium or the azithromycin. You could also add on low doses of oral corticosteroids. And as I mentioned earlier, really thinking about stopping those ineffective therapies. So some of the different, so the GINA strategy talks about maybe what is an appropriate biologic to start first, and really looking at some of these different ones. There are ones that target IgE, there's ones that target IL-5, which targets the eosinophils, and there's this IL-4, which also targets eosinophils as well. So there's definitely different factors that could predict a good response to each of these. So definitely if somebody has higher blood eosinophils greater than 260 and higher nitric oxide levels and allergy-driven symptoms, and if they're childhood onset asthma, the anti-IgE may be more effective. Whereas for the anti-IL-5s, again, if you have higher blood eosinophils, are exacerbation prone, if they have more adult onset asthma, and if they have nasal polyps, and this is one to consider. And then further, what other factors for this anti-IL-4 are, again, higher blood eosinophils and nitric oxide. So, you would choose one of these and you want to trial it for at least 4 months, and then you assess the response. And if you have a good response, then of course you would continue that therapy. But if you do not have a good response, then you would stop that therapy and really consider switching to a different, maybe to one of the different type 2 targeted therapies if they're eligible. But if none of the treatments are working, definitely you want to maybe reassess their phenotype and the treatment options. You may want to consider imaging to see, again, is this the right diagnosis, or if there's progression of a disease, considering some of these other therapies like bronchothermoplasty. And definitely, as I mentioned earlier, stopping ineffective add-on therapies. So again, if there is a good response to this type 2 targeted therapy, definitely reevaluating patients every 3 to 6 months. And then for definitely, if they're doing well, considering stopping or decreasing the oral corticosteroids. Probably that would be the first one. And then also considering decreasing some of the inhaled treatments as well. And really over time, reevaluate the need for ongoing biologic therapy. I've had some amazing results with some of these therapies where some people were on oral steroids as well as high doses of the inhaled steroids, and now they've been on a biologic therapy and have been able to just be on a very low dose of an inhaled steroid. So it is definitely nice to see that. So I am actually going to, so I kind of went over a lot. I know the GINA strategy over, a short period of time, but they do have some pocket guides, which are some really great resources. If you just Google GINA asthma guidelines, you'll find that. But I did want to segue in because in addition to these new severe asthma management guidelines, we also are doing and are involved in some new research approaches to treating severe asthma. So I'd like to introduce two people, Lauren Castro and Wendy Haas. They are both also from the University of Illinois, and they're going to be talking again about a new approach to looking at new therapies for treating asthma.
Great. Thank you, Dr. Nienhuis. So we want to just really quickly give some information on a study called PRECISE. And PRECISE fits in just perfectly with what Sharmili has shared, that there is some asthma, as you all well know, that is either difficult to treat or severe in nature. And so we're all trying to work together to figure out how to best care for these participants. Next slide. So what we have right now is essentially what Sharmili just discussed. So, lots of research and patients taking these medications over time has showed, as Sharmili said, sometimes she gives patients those medications and they have great results. But essentially we have all different kinds of patients, and we really kind of send everybody down the same road, and that path works for some people and it doesn't work for other people. So some people, get benefit and everything's great. Other people get benefit, but they also get side effects that may or may not be tolerable. And some people don't get any benefits at all and also might have side effects with that. And so that, of course, is not ideal, right? That's not the most, it's kind of a trial and error sort of path. And that's okay, but we're really hoping that we can turn the corner and find a little bit more efficient way of doing that. Next slide. So what the PRECISE study is looking at is using what we call a precision medicine format. And so wouldn't it be nice if we knew that from the beginning which kinds of medicines were going to work best for which kinds of patients? And that's exactly what precision medicine is. And this is being done in other fields. So we're seeing this working in the cancer space, that we're able to more precisely target certain treatments for certain kinds of patients. And so we do this by what we call biomarkers, and we can get these from different specimens from patients. So we can look at some of the very specific things in people's blood, in their sputum, and through some other kinds of testing to kind of put people into different kinds of groups based on those biomarkers. And then, based on all of the science and the research that's been done to date, to kind of understand, well, if you fit into group A, then this kind of treatment is more likely to work for you. And so that hopefully then, what we hope over time is that will take away some of that trial and error, and we can more quickly get to the best treatment for a given patient. So the study that we're doing right now, Sharmili and several other physicians at UIC and all around the country actually are taking part in this NIH-funded project, is that we're looking for participants that are willing to join that study. So I'm going to just a little bit about the study, I guess, is kind of exactly what I've just said. So we're trying to use these groups of patients. So we ask people, are they willing to join our project? We do some initial sort of procedures to understand, which of those groups you might fit in and understand how asthma looks for a given patient. And then this project has 6 different medications. You can see them listed there in the black text. And those are the medications that we're looking at in this project. And we are then able to assess over time which of these medications will be best for a given patient. We have 30 sites across the country doing this, so it's a pretty big project. And over throughout the entire country, there'll be up to 800 people participating. So we have a great team at UIC that is leading this effort. And I'm going to pass it off to Wendy, and she's going to tell a little bit more about the kinds of patients that we're looking for.
Thank you, Lauren. Hello, I'm Wendy. I'm a study coordinator at the Breathe Chicago Center at UIC for the PRECISE study. And so just to kind of give you a little bit of background in terms of the eligibility criteria for the PRECISE study. So at UIC, we are enrolling individuals that are over 18 years old and that have, again, that uncontrolled or difficult to treat severe asthma. And so a few of the factors that we look at to kind of assess that is poor symptom control. So, for patients, this might just be more of, them having an idea of that, oh, my symptoms aren't controlled. But for providers, looking at ACT scores or ACQ scores to see if symptoms aren't controlled. As well as looking at spirometry values, so patients having an FEV1 less than 80% and bronchodilator reversibility of 12% or more, or, again, kind of targeting that uncontrolled piece, individuals that have had greater than or equal to 1 exacerbation in the prior year. And so on top of that, uncontrolled asthma in adults, we're looking again at individuals that have been prescribed and are taking a medium or high dose inhaled corticosteroid, and another controller. So, if they're on combination therapy like Symbicort or something, that would suffice. But otherwise, if they're just taking an ICS, then another controller, which might include a biologic or something of that nature. So those are the kind of main high-level criteria. And so if anyone, has any questions or patients that are interested, or, is a provider and has patients that they think might fit for this study or be interested in learning more, please don't hesitate to give us a call. My phone number and email are there. So, don't hesitate to give us a call or send me an email with any referrals or questions or, friends, family members, anything like that. This project, again, is looking at individuals that have gone down several roads for different treatments for their asthma. So it's kind of another option for individuals to not only get back to the asthma community, but also, maybe find out more about their own asthma and what can be targeted to treat those individuals. So, yeah.
And Shamili, to throw it back to you, if there's anything from the provider perspective, I know we've worked with you and several of your patients.
Yeah. So, I think as I was able to show, it definitely seems like we're starting to get into this precision medicine. But we still have a lot more work to do, especially for that non-T2 type of inflammation. But I think even within that T2 type of inflammation, not always, these targeted agents or biologics that are currently available work for all patients. So I think the study is a really big step to really look at what other therapies can we find that may be effective for more patients, because sometimes especially in the severe asthma, maybe, or definitely at least uncontrolled asthma, maybe about 40 to 50% of adults may have this type 2 inflammation. So there's still about half of them that might have this non-T2 type of inflammation. And I think that's where this study is really going to be helpful in trying to find what are some of the best therapies for the other half of our difficult to treat asthma patients. So I know I think we're just running about 5 minutes behind, but definitely now we can take any questions. Shelby, so if you want to put any questions in the chat, then I can go ahead and try to answer them, or Lauren or Wendy as well. So. So
I
I
don't
think,
see any questions, but I was going to say I would also invite people to maybe unmute if they're on their phone and can't get to the chat function. If you're not able to chat your question, just go ahead and unmute and ask your question.
yeah, that would be great. I think Dr. Kumar had put something in the chat, at least just because as Wendy had indicated at UIC, we are looking at adults, but there are some sites across the country, and Lurie Children's is one of them, that are recruiting adolescents from ages 12 to 17. So, so again, that would be, you can definitely reach out to Dr. Kumar if you can direct message them, or I'm sure he could probably provide some contact information in the chat if you know any adolescents that may be interested in this study.
Thank you, Cheryl.
Yeah, no problem. Okay, well, we will have another question answer period after Dr. Kumar's talk. So if any other questions regarding severe asthma come up, please feel free to discuss then. Shelby, we were going to take a break, maybe just for maybe 4 minutes, so maybe we can come back at 9:25.
Sure, sounds good.
Yep. And so if anyone needs refill on their coffee or whatever.
Shelby, while we're waiting, can you verify that you can see my screen and that it's a PowerPoint?
Yeah, I can see it, Raj,
Oh, wonderful, thanks.
and we can hear you well, so that's good.
My camera over to.
I'm glad you were able to make it back.
Yeah, thanks.
Yeah.
And do you guys want me to sort of speed things up to stay on time? Would that be helpful?
We're okay on time. I think we had some technical difficulties at the beginning, so we started about 5 minutes late. But I think we'll be okay. I think we were thinking probably by like around 10-ish, 10:05, we would start doing question and answer, but we still have plenty of room. So,
Okay, wonderful. Sounds good.
okay, well, we'll go ahead and get started. As I mentioned, Dr. Rajesh Kumar, professor of medicine at Northwestern, will be giving a talk on looking at another precision medicine approach for asthma. Go ahead, Raj.
Thanks very much, Emily. So I was asked to talk about some of our recent research, and this is a little bit of a shift from talking about established severe asthma to think about ways in which we can potentially look at changing immune development to try and deviate at-risk children away from developing asthmatic airway inflammation and decrease the chances that they have asthma, potentially. So we're going to talk about Pi-1 soy isoflavones, but before that, a lot of the talk, we're going to talk about sort of how viruses contribute to the development of asthma. So these are my disclosures. I have you can see my grant funding there. I have a consultant for Regeneron, but it's really for things like patient-reported outcomes, so there's no conflict with anything I'm going to tell you about today. And so in terms of objectives for today, the things I thought we'd talk about is, understanding how viral illness may contribute to development of asthma, how the virus itself may modify that risk, and how the host factors like the patient's particular characteristics may modify that, and understand then secondarily the role of this molecule. I'm going to talk about Pi-1 in airway disease and how that could be a model for precision medicine, determining people who are at particular risk and potentially interrupting that risk. In terms of the viruses, we're going to talk a little bit about recurrent wheezing and who goes on to have asthma and who doesn't, the role of the viruses, and so we'll go into that now. So in terms of recurrent wheezing, this occurs only in some of the kids who have viral illness, and their progression to asthma again is only in a portion of those kids. So if you took all comers, about 60% of kids who wheeze do not go on to have asthma. The remaining 40% do. And in this group, viral illness is potentially important in the context of the kind of response they have to that virus in early life. This is associated with modeling, and therefore any intervention needs to be particularly pointed to the kids who are at high risk there. So I'm going to show you some data to back up some of these statements in the next few slides. So first of all, just talking about wheezing. You're all probably familiar with the modified asthma predictive index, whereby we can say if you have certain risk factors, your risk of going on to have persistent wheezing is about 80% by the time they're 6. So the likelihood that they actually are asthmatic. Now, what you'll see is this is another tool called the PARS score, which is works a little bit better at prediction across the spectrum of risk. But one of the things that is the same for this and multiple other scores is respiratory morbidity in the first few years of life. So if you get a lot of wheezing in the first few years of life, you're more likely to go on to have asthma, and that's uniform. And it's particularly with viral illness. So most people have said, well, maybe that's just something that unmasks that these kids were going to wheeze anyway. They just, that was just their trigger. The interesting thing is that that may not necessarily be the case. And this is some interesting data. It's old data, but it's very interesting because they found that if the kids were around 3 to 4 months of age in Tina Harder's group, that if they were about 3 to 4 months of age at the peak when they had viral illnesses exposures, that they were much more likely to go on to have recurrent wheezing, and they're also much more likely to have asthma by the time they were 5 to 6 years of age. So what we're saying is that the time at which you get the virus is important. So it's not necessarily just a second hit. Then also, if you look at the types of virus, and this is studied by Jim Gurn's group at Madison, Wisconsin, what you can see in the red bars here are these are kids who wheeze frequently with rhinovirus. And in the green bars were kids who, or I should say, these are wheezing frequently with rhinovirus. I don't know if you can see my pointer, but if you can. And the green bars, kids who didn't really wheeze with rhinovirus. Across this way, on the sort of the z-axis, you'll see that when you get up to the highest level, it's the kids who are wheezing with both rhinovirus and RSV. But really, it's quite striking that if you wheeze with rhinovirus, you're much more likely to go on to have asthma. And their risk was about 6-fold. So the type of virus seems to be important as well. Now, what about the host? Now, remember we talked about allergic and non-allergic or Th2 high asthma. And what you can see here is that if you see these kids who are sensitized, that had allergic sensitization in the top graph, you see those sort of orange triangles, they were much more likely to go on to have asthma by the time they were 6, 8, 11, 13 years of age, if they had wheezed with a viral illness in the first years of life. So that's dramatically more so than the same ages in kids who were not allergic by the time they were 5. They were much less likely to go on to have asthma, even if they wheezed in the first few years of life with viral illness. So much so that if you both had wheezed with rhinovirus and were sensitized by age 3, the risk in this coast cohort of going on to have asthma was 45-fold. That's huge. So the point here is that timing at which you get exposed to a virus, the particular virus, and also host factors like allergic predisposition dramatically increase the risk of going on to have asthma. And that's not just whether you have allergic disease. I'm showing you here an example that there are other more subtle host factors like genetic variation, which may predispose you to more likely going on to have asthma. What I'm showing here is some data from Carol Ober's group using the COAST cohort, where they looked at one of the most common genes that's found in GWAS for asthma. And what they found is if they had the risk allele for this ORMDL3 gene, and they wheezed with viral illness, all of a sudden, if they were heterozygote, or especially if they're homozygote, it dramatically increased the risk for asthma. There's a gene by virus interaction here. So this suggests that there are additional factors which determine viral response in the development of asthma. And that's one of the things that brought us to look at PI1. And I'll show now, before we go on to that, people will say, well, how do we know these early wheezing kids have asthma at this point? And, it's interesting, there have been relatively few histologic studies, but this is one where what they did was they did bronchoscopies on kids who were considered confirmed wheezers, as the doctor saw them wheeze. Kids who were reported wheezers, the parents said they wheezed. and controls who get biopsies because they had other things like subglottic stenosis that they had to have bronchoscopy for. And what they found was that there was much more basement membrane thickening and lots more eosinophilia in these people who were confirmed wheezing, meaning that they were probably more severe wheezing showing up at doctors. And so the point being, you're seeing some of the pathognomonic features of asthma, kind of airway remodeling that happens with asthma early in life. Similarly, if we look at really old data from the Tucson Childhood Respiratory Health Study, and there's been multiple studies since which show the same thing, including in Australia by Peter LeSwift, what they found was that if you were somebody who went on to wheeze later in life, you start out with what looked like relatively normal lung function when they did sort of compression vests to do a forced expiratory maneuver. And then they found that those kids who went on to have persistent wheezing had lower lung function by the time they were 6. Now, the Australian study suggests that that happens actually in the first year of life, so the curve may actually really look like this. Now, why is that important? What that suggests is not only you're having airway remodeling, it's affecting lung function, and that's important because lung function tracks over time. And what you can see here is this is a study called the MESCA study, and it's pretty interesting. What you see is this SA is severe asthma. These are used old terms because it was started more than 40 years ago. A is what we call moderate asthma. WB they call wheezy bronchitis, which is we call mild persistent asthma. Mild wheezy bronchitis here would be intermittent asthma, and C is controls. And what you see here is as you go down in terms of greater severity of disease, the severe asthmatics clearly have much more affected lung function, and that difference in lung function tends to track. Now, since then, the CAP study, which was a study looking at asthma over the teenage years and into early adolescence, early adulthood, found that some of these people who fit in this group are actually people who also start declining early, and there's a proportion of these people who actually meet criteria for COPD in early adulthood. So the point being that that if we are seeing a virus affecting lung function early in life and it is severe enough, you are increasing the risk of that person throughout their lifespan. So the point, what we're saying therefore is that any intervention that we take here needs to occur early. It needs to be directed to the right people because not everybody's at the same risk. And preferably anything we do will affect both immune deviation and airway remodeling. And finally, it needs to be safe. So that led us to, as I said, the pi1 and soy isoflavones story. So on your left here, you see the pi1 molecule, which let's talk to you about in a bit. And this is their friendly soybean here. So what is pi1? Pi1 is a molecule that does many things throughout the body, but in the airway, it does two main things. One is it promotes, blocks the production of plasmin. So with that, you see more fibrin deposition, and it also blocks metalloproteinases, so they don't break down the collagen, so you get more remodeling. So that's one thing. Oh, sorry. And then the other thing it does is that and this is something that's new that we've discovered, is it promotes one of the master regulators of the allergic response called TSLP. And it makes more of that Th2 high inflammation that you guys heard about earlier from Dr. Ninehouse. Now, here I'm showing you an example of what this does. This is a mouse model, but on the left-hand column, these are normal mice who have normal amounts of pi1. In the right-hand column, these are mice that have pi1 knocked out. And what you can see is that when they have just normal saline challenges, they have normal airways. But in the mouse that produces pi1, you do an allergic challenge and they see lots of mucus plugging, you see lots of airway remodeling and collagen deposition, and you see damage to the airway itself. You don't see that in the knockout mouse. So you're seeing that it sort of shows you how important it is in the allergic response. And in terms of the airway inflammation, I'm not going to go over all of this, but looking at this cartoon sort of hits the main point that I think is important here, is that PI1, which is produced by mast cells and also by epithelial cells, especially in models which are allergic models with virus-like stimulation, they've been shown to increase this TSLP production. And TSLP is important because it acts on myeloid dendritic cells to shift T cells in the airway to more of that Th2 allergic type of pathway. That results in more of those allergic eosinophils. It also results in more IgE being produced. So you get this sort of allergic airway inflammation when you get a viral insult, because you're getting more TSLP. And the IgE is also important because we know that if your IgE is higher, then that interferes with plasmacytoid dendritic cells, interferon responses to virus. So and what we found here is that when we have people who have a genotype that results in more PI1 being made, their IgE is higher, and so they are going to have worse antiviral responses. So you've got sort of a double hit there. Why are we talking about this molecule? Why is it important? Well, the reason is that we have found or it's not we, there is, I should say, a genetic polymorphism, a variation, a misspelling in the gene, or upstream of where the part that's the protein, a misspelling in the part of the gene that is called a promoter and determines how much of a product is produced, how much PI1 is produced. So what happens is if you have this misspelling, this 4G repeat instead of this 5G repeat, you get preferential activation of the gene. You get lots more PI1 produced. And there are lots of genes that are there in asthma. This is important because in various different populations, up to about 60 to 70% of them have this genotype, which means that anything we do in the general population could affect up to about 60% of individuals who are at risk for asthma. So it becomes important because it's very common and it's functional. And so if we can do something to target that specifically, it could help people. Also, it's important because we know it's higher. Asthmatics produce more of this compared to controls and their airway. And also, when you get a viral illness, the levels jump up after 5 to 7 days, and by about a few weeks after that, they go back down to normal. But the bottom line is, not only asthmatics are producing more, they're producing much more when they get a viral illness. So this led us to question, if PI1 is important in making allergic airway disease, if you had this mutation where you made more PI1 and had a severe early life viral illness, do you get more likelihood of going on to have asthma? Does it affect your lung function, as we would expect that it would? And when we looked in the GALA study, which is a study of 4,000 children with and without asthma that was started at UCSF, and we were one of the sites of that, we looked at the data and we found that the individuals who had the risk, here's people who had the normal genotype and had no severe RSV illness. Here are people who had the risk genotype, but they didn't have any severe viral illness. So again, no increased risk. Now, if you have the normal genotype and was a severe RSV illness, you see an increased risk of going on to have asthma. But when you have both, the risk was 17 to 18-fold higher and this is the interaction term. So there's a gene by virus type interaction. And I grouped the people who have 1 copy and 2 copies together because the numbers got smaller when we separated them. But you can see that there's a dose effect. No copies, but the virus. here you see 15-fold increase with just one copy of the virus, and here you see 25-fold increase with 2 copies of the virus. Now the numbers are small, makes the confidence intervals wide, so we can't really say this is necessarily different, but it's suggestive of a dose effect, which is again one of the things we look for in causality. We also see a change in their lung function if they have this early life lower respiratory tract illness and the risk allele. You see differences in FE1, differences in FVC, and you see increased likelihood of obstruction. So in summary, this genotype by itself doesn't have an important risk for asthma, but together with a severe early life viral illness, it has a definite effect on the outcome of asthma. And, you know, and also some effects on lung function. So this led us to think, well, can we interrupt this? And, you know, there's some work that my colleague Song Cho at USF has done. And what he found was if we use soy isoflavones, we can decrease the expression of Pi1 in airway cells in culture. And, you know, we can also show less protein being produced as well. Now, we've additionally done a lot of mouse work, or rather Song's done a lot of mouse work, which I showed you one experiment before that suggests that this can be interrupted using soy isoflavone. But the other thing that is interesting is we also had a colleague, Lou Smith at Northwestern, who did a study called the SOIA study that was looking at whether soy isoflavones could modulate the development of, or the severity of asthma rather, in people who had established asthma. And when they did that study, we found that there was a decrease in Pi1 production when we gave them soy isoflavones. And when you look at the people who had the genotype, you see a definite decrease in exacerbations. Now, you don't see that when you see all comers, and that's why the initial study looked negative, but when we reanalyzed the data, that's what we saw. So there's animal model data, there's cell data, and there's human data suggesting that this soy isoflavone affects the Pi1 pathway. So we currently are doing a study called SIRA, which is soy isoflavones for inner city infants at risk for asthma. It's myself and Dr. Pograsic here at Lurie Children's. Our collaborators include Song Cho, who's done a lot of the basic science work on this pathway and is going to be doing mechanistic work there. And we're collaborating also with a group at Denver because this is part of the Childhood Asthma and Urban Environment Study, or CAUSE Consortium. And so we are working together because we will be able to look at things like how airway gene expression changes and how lung function changes using some novel methods that are not invasive and just measure lung function over the course of the night's sleep in infants. So so we wanted to study this in inner city infants, and one of the questions could be, why inner city infants? And there are 3 reasons. First is, you know, asthma has sort of become stable in its prevalence. It was increasing through to the late 90s and early 2000s, it became stable. But the disparity among African American versus whites and certain Latino ethnicities versus whites continues to increase. And you can see that in this data from Lara Akinbami, where if you look here, the green line continues to sort of increase, whereas the blue line of white subjects has sort of stabilized. Similarly, while this data is a little older, it's not very different now. What you see is the African Americans have much higher rates of ED visits, even if you account for prevalence. You know, that's about 2 to 3 times higher. Their hospitalizations are about twice as high, and their deaths are about 4 times as high from asthma, and that accounts for prevalence. So what that means is that, there's a significant disparity. These children who are urban minority children are at higher risk, which we know, and they are both of asthma and worse disease. And that's both the case in Afro-Caribbean populations and African-American populations, which you can see in the top graph here. So that's why these kids are, we thought, the ones we really need to help. But also, I have a picture of Penny here. And the reason I have a picture of Penny is that soy isoflavones are pennies a day, as compared to, say, giving somebody a monoclonal antibody. If we can use something that's relatively safe and inexpensive in this population, it can be scalable and make a difference to the likelihood that they go on to have asthma. So what we're in the process of getting set up is a randomized clinical trial. It is a study where we will take kids within the first year of life and give them soy isoflavones at the same level that they would have had if they were drinking soy formula. They have to be 2 to 6 months of age between May and July, so that they're the right age when they hit the viral peak. They then will either get soy isoflavone or placebo. They will continue receiving that till March 1st, at which point, we see less circulating virus in normal years, not COVID years. And then we have a year of observation where we continue to follow their wheezing, as well as we assess their airway endotype by nasal brushings, both at the beginning, at the end of treatment, at the end of the observation year. So that's our hope, is that we would see a change in the types of airway inflammation in this group of individuals who are treated with soy isoflavone. If we do, that would lead to the next step of thinking about whether we could carry out a more prolonged interventional study. Now, what about safety? With this, as I said, we're using the amounts of soy isoflavones that you'd see in soy formula. It's basically an extract of soy protein, it's a phytoestrogen, but there's no conclusive evidence based on, and this is a statement from the AAP, that animal, adult human or infant populations, that dietary soy isoflavones affect development, reproduction, or endocrine function. And so what I've got below here is some of the studies that sort of went into that kind of statement and have been done since. And basically the bottom line is, if you got the only thing I could find after combing the literature that would be significant is that you might see about a less than 4-month increase delay in menarche in infant girls who were fed soy isoflavones before 4 months of age. For most of these kids, it's going to be after 4 months of age, and there was no effect even in that one study, the ALSPAC study. So generally pretty safe. So the take-home lessons here are, I think, that viral infection in early life increases the risk in susceptible individuals, particularly if they're allergic, and that any intervention that we can carry out in this process needs to be driven by host factors and needs to be relatively safe to be implemented early on. I've shown you one of the things we're planning to do. There are other studies going on right now looking at other options as well. So, I think this is an area that's sort of the next area of research for asthma in development, and looking at sort of really identifying who's at risk and whether we can intervene at an early stage. I've got some references here if people are interested that I think are good sort of general references. One about reviewing the evidence for early life respiratory viral infections and development of asthma. Another looking about, asthma phenotypes in childhood. And then one that is a nice study when we reanalyzed the soy isoflavone and exacerbation data in the soya study, which initially didn't show benefit in Lou's initial report. Finally, I'm presenting this to you now, but this is the product of a lot of work from a lot of different people, principally my co-investigator Song Cho, who's done much, if not most of all the basic science work that this was based on, as well as the Gala 2 team and the Denver team, including Max Seibold, as well as the Soya team, including Lou Smith and Ravi Kauhan. So this is the funding for all of those studies, including the SIRA study, which I showed you. And I thank you for your time and open to any questions.
Thank you, Raj. That was a great talk. So at this time, if anyone has any questions, please feel free to put your questions in the chat. I did have one question, Raj. Have there been epidemiologic studies looking at maybe inner city populations to see if they have, what their diet makeup is, and do they have like low soy isoflavoine intake? I was just curious. I don't know.
It's not so much that they're. I don't think that this is a problem of soy isoflavoine deficiency.
Yeah.
It's more that these children are at risk because of multiple other factors that increase the likelihood that if they have that they'll have severe early life viral illness, and two, that they are more likely to be prone to atopic disease, some of which may be epigenetic related, and that the point is more that in those kids, if you have the PI1 genotype, which is about 60% of most kids would, then those kids are at higher risk of going on to have asthma. And if we can block that pathway when they get that first virus, then we might have the ability to intervene. It's not so much that there's a deficiency. I mean, I'll say that if you look at, say, Seventh-day Adventists or Korean or Japanese populations, they have much higher soy intake than we do. But I wouldn't say that and I would say that probably in the inner city there's less soy intake than, say, middle class or upper middle class children. But in general, the hypothesis isn't that it's a deficiency, but rather this is something that we can use to target this specific pathway in kids who are at risk. And the reason you think about the inner city kids is they're really dramatically at risk. I mean, 20 years ago when we first were doing something called the CHIRA study, where we looked at the likelihood that they were going to that these kids had asthma, when we looked at did some screening in schools, in Chicago public schools. When you start looking at some of these inner city schools, the rates of undiagnosed and diagnosed asthma together reached almost 20%. So it's not like the 8% in the general population. They're really at risk of worse, both more disease and worse disease.
Yeah,
So
and I
that's
think
why
in some communities, it's even up to 40 or 50% within
Right.
Chicago. Yeah, I think
Right,
that's just
right.
kind of the average is the 20%. So
Yeah.
no, I think it was really interesting because I think you're really focusing on preventative, like how can we prevent asthma? So this is a targeted way, again, using precision medicine to really identify and then hopefully prevent asthma in these at-risk infants. So
Right, because if we can do something like that, then we can dramatically decrease the healthcare the burden on these families and patients throughout their lifespan, but also decrease healthcare costs and effects on the community. So I think it has sort of, if we could actually do something early, I think it would make a difference compared to, once the disease is established, then it's sort of fighting just for control, like control of diabetes as opposed to prevention of diabetes.
yeah, thank you. As we said earlier, if you're on your phone and aren't able to type in the chat, please feel free to unmute yourself and ask any questions of Dr. Kumar or myself from the talks.
And if you have questions, or we're not going to be recruiting probably till later this year or next year. I'm just going to put in my email into the chat. So that if you are interested in sort of helping this study move along, oops, I sent it to Shelby instead of everybody else. I'll try that again, sorry. If you're interested in helping this study move along, and we will definitely need help because it's not going to be an easy study to recruit from, you know, please do reach out to me.
Okay, yeah, so thank you. Yeah, if there, Dr. Kumar put his email in the chat. Shelby, do you want to put up the final slides? Okay, so I guess it's your lucky Friday. Then we'll probably go ahead and a little bit early today. You can get 30 minutes extra of your Friday morning. But again, we just really like to thank speakers, I guess myself and Dr. Kumar for taking the time to talk to us about some of the new and up and coming research going on in regards to asthma. And again, there's a lot of opportunities for people to participate, or if you know of anyone that is interested in wanting to learn more about the research opportunities, definitely I think we've provided some resources. And I don't know, Kim or Shelby, if we can put that on the website, but I guess we can talk about that. And again, we just like to thank our sponsor, AstraZeneca, so we could put on this program for everyone today. And just wanted to let everyone know we do have some resources that are going to be coming out on tenant guidelines. So what to look for when you're looking for a place to live, as far as looking at environmental exposures. And also we have our Kick Asthma video series. We will be sending out probably on Monday the evaluation for the program. So thank you so much for your help today, or for your participation in the program. And we'll see you at our next professional development series.
Thank you, everybody. I hope you all have a great Friday.
Yeah, bye.
Bye.
Thank you.
Thank you.